Tills et al. Has an interesting piece in JACC, Catheter Ablation of Long-Standing Persistent AF. It's the 5-year outcomes of the Hamburg Sequential Ablation Strategy. And I'm with Dr. Andrea Natale, who is the Executive Medical Director of the Texas Cardiac Arrhythmia Institute in Austin. And you had an accompanying editorial, which I particularly thought was good. The Metastatic Cancer of Electrophysiology is how you explained long-standing persistent AF. Can you first off talk about Tills et al. And the paper that you're commenting on in JACC?
The paper coming from the group in Hamburg is a study that has to be done because we need those information to sort of support different type of strategy in ablating patients with long-standing persistent atrial fibrillation. But in a way, people that are involved in this field already sort of have experience and knew the answer. And what they did, they had sort of a stepwise approach to the ablation, starting with the pulmonary vein only, and then if the pulmonary vein was not sufficient, then they move on to adjunctive lesion. And I think the people involved in this field, they already know that pulmonary vein alone, ablation of the pulmonary vein alone in patients with long-standing persistent atrial fibrillation have a dismal effect, which is what they show. And the reason why we use this term of metastatic cancer is because what we realized by dealing with this patient in the ablation lab is that it's never about a single site. This seems to be sort of a diffuse disease that involves multiple locations that can potentially trigger a reinitiated fibrillation, similar to what a metastatic cancer look like. So it's an important study because provide more scientific evidence of what clinician involved in the field already knew, but it's something that has to be done. And from now on, I think we have to move on to sort of the proper strategy to address this patient population. Otherwise, the conventional approach, which involves isolation of the pulmonary vein, really doesn't do the job that we need to achieve to justify an invasive procedure.
And sometimes it takes more than one procedure in order to actually get it done.
Yes, this is absolutely true, even if you really try to do the most that you can, or the most what you think is appropriate. And one of the limitations of this procedure is in part the experience of the operator, in part the tool that we have that do not necessarily achieve permanent lesion. This is really the holy grail of this field, the inability to achieve permanent lesion in some area. Part of this is related to the operator experience, but part of this is related to the tool that we have that really do not make our job easier. So it's a combination of things. So even in the best case scenario where the operator try to really be more comprehensive in the approach that is used into ablation of long-standing persistent atrial fibrillation, there are limitations that require a second procedure coming from the type of tool that we have today at our disposal.
The one thing to keep in mind is that even though it has comparisons with metastatic cancer, the majority of patients will benefit over time.
Absolutely, absolutely. We actually, our practice is involved with ablation of a large number of this type of patient, and we really have a very close follow-up where we do quality of life. In some of them we do metabolic stress tests before and after, and despite of the amount of ablation sometimes needs to be done to cure the problem, pretty much all these patients feel better after. They feel that they have more an improved exercise capacity, better quality of life, so it's still worth it to do this, even if it takes more than one procedure.
Well, I thought it was a really good paper, and I thank you for doing it, and thank you for offering, if you can, just a summary as what the clinical take-home message of both of these papers.
I think what comes out from Tills' paper is that in patients with long-standing persistent atrial fibrillation, pulmonary vein isolation alone has a minimal impact on controlling atrial fibrillation. Some of us don't like to use the term cure. I am more positive. I hope, and I think in our patients we see cure for many, many years. As long as we do the right procedure. And the right procedure, I think, in this group include certainly pulmonary vein isolation, but addressing other side that potentially can be triggers, and there are several that has been described and reported in the literature. This is really the important key message. Don't stop with the pulmonary vein, go beyond that. And if you do that, I think operator will experience a much higher success, and patient also will benefit from it.
Well, persistent atrial fibrillation is a really difficult situation, and the idea of this as metastatic cancer of electrophysiology is a really good one. The editorial is in JACC from Dr. Natale and all, and then Tills et al. Has the original paper in the Journal of the American College of Cardiology. For CardioSource World News, I'm Rick McGuire.